Okay, so we're moving on past the Progressive Era and all the changes that accompanied that into the Roaring Twenties and the Great Depression and the implications on healthcare. So let's consider in our discussions to follow the consequences of the Great Depression on societal perspectives as to the role of government and societal perspectives on capitalism. And maybe we could think about how that might have changed in recent decades. We'll also explore in this section some of the cooperative innovations that developed in health insurance and health delivery in that setting. And we'll also talk about the origins of the health maintenance organization and might consider how the ideology of managed care has changed from then to now. So the Great War to end all wars, World War I ended in 1918, and new discoveries brought new costs to healthcare. We know that Frederick Banting and Charles Best discovered insulin, which really stayed the death sentences of childhood diabetes, insulin-dependent diabetes. Banting and Best thought it was unethical to profit from their insulin discovery since it could save so many lives, and they sold the patent for insulin to the University of Toronto for $1. Times do change. X-rays were advanced at that time, well beyond Madame Curie. Surgical techniques and anesthesia advanced. Vitamin D was discovered. All sorts of incredible research in terms of metabolism, Krebs cycle, and a lot of the other stuff you might have learned in your basic sciences was having its origins during this time, with really relatively primitive techniques and amazing ingenuity. As hospital and surgical care did advance, however, treatment became more pervasive. Routinely, people would have appendectomies performed, and people still paid out of pocket for medical care, but by the 1920s, persons could no longer predict their future costs and need for medical care. We discussed this in one of the preceding slides about the necessity for insurance. Still, even at that time, healthcare only accounted for a modest amount of GNP. It accounted for less than 1% of GNP prior to 1936. The 20s, we saw 4 million men demobilized, actually in the middle of a lethal influenza pandemic. And they returned to a society where mass production, the Model T, the Ford, the automobiles, telephone, new appliances, fueled the U.S. economy. And during this time of interest, there was also relatively low wages, so people may not have had the wherewithal to afford many of these devices. And there was overproduction of produce also, which decreased farmers' wages. So here's some Model Ts rolling off the assembly line. Here's some folks working, in a textile mill. And the 1920 saw the 19th Amendment finally ratified to allow women to vote. Prohibition developed. The culture was changing due to the presence of movies and radio. Jazz entered into the modern mind, while overseas, fascism in a destroyed Germany and struggling economies of Europe was ascending. And communism was enacted in Russia during this time. The U.S., here's a picture of prohibition and some whiskey being poured out of barrels. Of course, our celebration of capitalism came to a rapid halt due to the great stock market crash of 1929. That was brought on by really overinvestment in stocks that were bought on margin and absent regulation of banks that were allowed to invest in the stock market, and a speculative bubble that was broken quickly with panic. So here's a local savings bank with a run on the banks. There was no guarantee that your money would be there as there is today. The Great Depression ensued, and there was widespread general strife, unemployment, insecurity, food insecurity, and Franklin Delano Roosevelt was elected in a landslide. Unemployment insurance and old age pensions were top of the list of essential government services to be introduced. The concept of a national health insurance was introduced and proposed, but the American Medical Association still had clout, and with many efforts during this period, it was not enacted. However, many components of the New Deal were, which included putting many people to work, creating large public works, and including the Grand Coulee Dam and other major Tennessee electrification and other major projects to put a society back to work. During this time, due to poverty, citizens were trying to avoid the use of a hospital if at all possible. Those beds did go empty. But despite that, compulsory national health bills, both introduced in 1934 and 38, were opposed. But people had to come up with other alternatives, other innovations. So there was the development of a group hospital insurance, which came to be known as Blue Cross. And the origins of Blue Cross was really at Baylor University Hospital, finding empty beds. Justin Kimball, who had previously been a former school superintendent, found that, maybe now with his new position as the manager of a hospital unit, he could develop a plan that would have the coverage for nurses and teachers' hospital stays prepaid. So he designed a nonprofit plan where nurses in Dallas and teachers could simply pay 50 cents a month to receive up to 21 days of hospital care each year. The hospitals would set the prices for the hospitalization, but it was a very successful plan that people were able to get their appendectomies or their deliveries or other medical interventions. And again, a typical American family during this time might have paid perhaps 5% of their annual income. An annual income of the day may have been $2,000. That was annual. And a family may only pay $103. But almost all of that was for hospital care. So the concept of Blue Cross was widely accepted and became a prominent form of health coverage, such that it expanded from 6 million people in 1940 to 78 million people by 1971. Remember those concepts of community rating versus individual underwriting? Well, it depended on community rating large populations of well people to keep things affordable. And the popularity of Blue Cross, for instance, is compared to Prudential Health, which in 1971 had 48 million covered lives. And that was a for-profit indemnity insurer, versus Blue Cross, which had 78 million. So this was at a time where government was pulling people's feet out of the fire. Poverty was widespread, unemployment was widespread, and social networks and safety nets needed to be established. In this context, people often would also develop community programs, one of which was Blue Shield, which was a nonprofit plan similar to that of Blue Cross, developed with the California Medical Association. And this, again, ultimately merged with Blue Cross Blue Shield in 1974, was offered by many communities, locally run by boards within a particular community, using community rating, and it was supported both by industry of that age as well as unions. And it was accepted by the American Medical Association and physicians since it wasn't government run. Ultimately, other innovations started to develop. Here we have a picture of a dam going up. This is probably the Grand Coulee Dam or many of the other major dams out west. That was in part funded by government support for the workers. And the relevance for that is these folks who are working on these dams would often have their family with them. They'd be far from the cities, far from typical medical care, and industry needed to find out how to take care of their injuries as well as their tuberculosis or their pneumonias or their health issues. So Kaiser Industrial, which was a major construction company in California, developed health coverage for the workers in its shipyards and steel factories. In doing so, Kaiser hired its own physicians. It built clinics and actually hospitals adjacent to their factories, and used a capitated basis, that is a provision of a certain payment per member per month to the programs. So an employer would pay a modest amount, the employer would pay the rest, and that would go to the essentially what was not called a health maintenance organization of the day, but a direct payment plan. And anyhow, this developed during the 30s, late 30s into the 40s, and ultimately became Kaiser Permanente in 1945. And by the way, there were other models going back to the 1910s where lumberjacks were having doctors hired to take care of their health care in the absence, again, of any other insurers or mechanisms. So this was the capitated health maintenance organization. And again, just to remind folks that capitation basically pays a set amount for each enrolled person assigned to that plan for a period of time, and you get that capitation whether or not the person seeks care. And the amount of remuneration to that plan is based on the average expected health utilization of those patients, which does vary by age and by health status. One of the things about the Kaiser Permanente plan, by the way, is they took care of folks' families as well as the worker, and they really pioneered a lot of understanding of of family dynamics, needs for family care, and developed the concepts of family medicine, as well as preventative care and longitudinal care to keep these families well. So these were direct service plans. You may know it as managed care today. In the 1990s, it was widely recognized as health maintenance organizations. There are different types of health maintenance organizations. We'll discuss this at a later session. But just briefly, a staff model HMO has the clinicians who take care of patients integrated into the same insurance organization that enrolls those patients, those subscribers. The HMO is directly responsible for the quality of services. An indemnity insurer, which may just reimburse you for your care, doesn't really have any input to a clinician's skill set or quality. A staff model HMO, which really is able to break even by keeping down costs, perceives that costs can be controlled by effective preventative care and quality care. These staff model HMOs control their financial risk by regulating facilities and the equipment available. And oftentimes it may not be the highest tech or most cutting edge technology as a consequence. Plus, the staff model HMO will limit the subscribers to care within their particular practice. Prepayment, primary care, and preventative care are all its hallmarks. Here's just a picture of one of the first. One of the first hospitals built near the shipyards near San Francisco. And the ideology is that of, again, preventative comprehensive care and limiting the costs at the point of treatment. So you're not going to be seeing gleaming atriums that you might enter into. The facilities are often just functional rather than luxurious. And in our discussion of this section, you might consider about how such health systems have been altered in our current age of financialization. Also, one might want to think about what a gatekeeper is, if you're not already familiar with that term. And we'll discuss further the deregulation of the 1990s, when heavy-handed utilization review and exclusion of pre-existing conditions and narrowing further of networks played a role with the popular perception of the HMO. So I think that's what we've got for this session, and you'll be able to read on your syllabus some of the questions to take away from this. See you soon.